About 75% of the cholesterol in our blood comes from the liver. The liver produces it. So even if you're a vegan and you have no animal products whatsoever, your liver is still going to produce cholesterol because it has to. It's essential for life. But then about 25% comes from the gut, from what you eat. And then that percentage can change according to the individual, which may be genetically imprinted. We don't know that. So the good thing about this lab is that they actually do markers that you can see what the problem is. So like, for example, this case is a hyperproducer. These are two, aldosterol, demonstrol. Those are two markers for hyperproduction. So that's in the red. Yes, the absorption in this patient is okay. So that's a patient where statins work, red yeast rice works. It's kind of a straightforward case. Now then this next case, and I see a lot of these. Now the problem is different. This person, their production is in the green. Maybe they're on a medication already, but their problem is the absorption. And that is really interesting to know, because if I just give them a statin or increase the statin dosage, it's not going to do much. So I have to look at what can help with absorption. And yeah, there's a medication called Zetia, which will help with that. But there's also things you can do naturally, which is a lot easier. I use a lot of artichoke extract, which can help with absorption, probiotics, especially the lactobacillus type. So there are things that it really helps to know what you're dealing with so you can adequately treat the patient. Again, this is what you do as an integrative cardiologist, looking outside the box, because this is not done on a regular basis, unfortunately. And then with the metabolic, and this is the other part of the equation that's so important. So what they're doing, oops, okay. So here, the A1C tells me metabolically how well the blood sugar has been controlled for the previous 3 months. So 5.7 is really borderline, so not great. It's a marker in the red blood cell, and the red blood cell lasts 90 days. That's why it makes no sense to do this should do it more than every 3 months. And HOMA, that's a homeostatic model of insulin resistance. That's a calculated value that is important for helping with insulin resistance. And the problem is that we're seeing more and more insulin resistance. And it's not just people that are overweight. We're seeing young people today who have a really lousy diet that are having measurements of insulin resistance before they get overweight, before they're pre-diabetic, before they're diabetic. So these are important measures. And then, of course, down here is the insulin, the fasting insulin. So that should be like 8, 7, maybe at the most 10. But I'm seeing a lot of people with high insulin numbers, which means that's the sine qua non for insulin resistance. Because what's happening, the insulin is kind of like it carries your sugar in the bloodstream to where it should be deposited for storage, which is liver and muscle. But in insulin resistance, the muscle cells, for example, they don't recognize your insulin, so they don't have the gate open. And so what happens, the blood sugar remains in the bloodstream, and you have a whole cascade of horrible events. One is which the body will make more insulin. So the body's making more insulin, and insulin is a fat storage hormone. So it's really hard for insulin-resistant people with high insulin levels to lose weight. So our objective is to change the cycle. It's just like a hamster in a wheel. That's the information we need to really have to treat a patient. And then we have the inflammatory markers here. This person really didn't do very well because the fibrinogen, oops, one more. The fibrinogen is high. That's a non-specific marker, an acute phase reactant. The CRP you've heard about, 3.4 is too high. And the LP-PLA2 is a specific marker for vascular inflammation. But we do know it's something going on in the vascular system. And that's why I showed this slide, because over here you see, I'm going to see if I can get this to work. Okay, this is actually a standard plaque. You have a necrotic pool of cholesterol and fats, and you have a nice thick fibrous cap. That's a stable plaque. That can be that way forever, for many, many years. Here you have the opposite. Here you have a necrotic pool. You have a very thin fibrous cap. And these are the patients that the plaque will rupture. See that break there? And then you develop a blood clot. And that's what happens when you have a heart attack. And that's what I had. I had a big blood clot. My blocker was like 40, 50%, but I had a blood clot. So that's the difference between a stable plaque and an unstable plaque. And since we can't identify when one becomes the other, that's why we have to do all this testing, and we keep it going so we can keep this from not occurring. They also do a fatty acid balance test, which is kind of interesting. It tells us kind of in the last 2 weeks what their diet is like when it comes to fat. And this is how it looks. Like, for example, these buttons. Okay. The top here, we want everybody to be in the green with trans fats. I mean, you should have no trans fats in your diet. So we want that to be in the green, which is good. Then we down here, the monounsaturated. Now, there's a little controversy now. Some people feel that having 2 polyphenols in your diet is like not good for your heart. I disagree with that. I don't think the evidence is there yet. I think monounsaturated fat is very good. Olive oil, nuts, etc. So that's why I like it. So this person was in the green, which is very good. And then down here, you have, this is very important. This is the omega-3. So there's 2 major fatty acids we're looking at, EPA and DHA. And this person's the yellow. And this is the kind of person I say, you know, you need fish oil. You need more fish in your diet, because I think that's really your protective fat. And then there's the genetics. So there's different markers that they do. That's a gene to see if you are prone to have problems with statins. You've all heard that statins can cause muscle aches and muscle weakness. Well, there's actually a genetic basis behind it. You could be a poor absorber so that the statin hangs around longer, and they think that's why you get the cramps and the weakness. So there's genetic testing we can do for that. There's ApoE down here, which does also tell the person's got a predilection to premature heart disease. And these are the people that tend to be hyper-absorbers, by the way. And it's also the same gene for Alzheimer's. Then factor 2 and factor 5 Leiden are blood clotting genes. And if you are positive of that, you tend to have a tendency for blood clotting, which isn't good if you've got heart disease. And then MTHFR is kind of if that tends to be elevated, these are the patients that often will have high homocysteine levels. So it gives us more information. And treatments, okay. It's all about lifestyle, okay? And this is where modern traditional medicine, I think, fails. But let's just list them all. There's lifestyle. There's medications. There's EECP, which has already been mentioned. I'll tell you a little bit more about that in a minute. There's balloon angioplasty and stenting. And, of course, there's bypass surgery. Now, I think traditional medicine does really well on 2, 4, and 5. They don't really do much EECP, and lifestyle, it really is a lot to be desired. Let's talk about lifestyle. Diet, okay. Now with heart disease, actually I have this listed for you. With diet and exercise, we talked about already supplements, which I'll talk about in a minute. Okay, Mediterranean diet. This diet has been studied more than any other diet when it comes to heart disease. So it is a relatively safe diet. I usually subscribe to it. It's got a little more carbs than I would like, but it's a healthy diet overall. The food is not processed, it's fresh, and we do have a lot of data behind it, so it is useful for heart disease. Now, Paleolithic diet, that's a step further. So basically, if it doesn't grow naturally outside or run in the wild, then it probably shouldn't be in your plate. And I kind of am in between Mediterranean and Paleolithic. I think they both have their place. The problem with Paleolithic, I think it's a pretty safe diet. The data isn't as strong. We don't have as many studies, and the studies that we have are relatively small number and small duration. But I think it does have its place. But the big one, and then the plant-based or vegan, which a lot of people, it's also a big push these days, but there's a lot of nutritional deficiencies that can arise with a vegan diet. So if you're going to go that way, I really suggest you work with a nutritional professional, a dietitian, or a certified nutritional counselor, because you have to know how to put together complete proteins. But this is the one that's getting a lot of attention, the ketogenic diet, which has already been alluded to. And I do find a role for that in certain cardiac patients. If they have a metabolic problem, like metabolic syndrome, prediabetes, diabetes, obesity, high triglycerides, fatty liver, that's the diet, I think, for that population. If they can follow it. And you have to work, again, with a professional to know how to follow it correctly. I had a patient that tried it. He said, I was on it for 30 days and I didn't go into ketosis. I said, I'm sorry. If you were in it for 30 days, you didn't go into ketosis, something is wrong. More than likely, you weren't really following the diet correctly. So you have to have someone who's really motivated. But everybody does lose weight on this diet. I haven't seen anyone not lose weight. And I do think and the good thing about it, it's an anti-inflammatory diet. And I've seen the inflammatory markers go down. I do not believe it's for everybody. I do not think there's one diet for everybody. It depends on what the goals are. But I have seen it work well in metabolic syndrome, and I get about 3 or 4 of those a month easy, new ones, young people, for people in their 30s and 40s. So it's rampant. Ever since we all know about the 90s, right? Everything was high carb and low fat. And what happened? It was a miserable failure. The country got fatter than ever, and we have diabetes as an epidemic now. So we know that didn't work. So we have to change things around. And so there is a role for that. There's a role for all these, really. Depends on what the goals are. As far as supplements are concerned, I'm pretty basic, you know. I believe coenzyme Q10 is very good. It helps with the biogenics of the heart. I use a lot of that in my practice. I use fish oil. Everybody over 40 can basically can benefit from fish oil. Vitamin T3 is a big one that I use. Probiotics, depending on the situation, and those are really the main ones that I use. And also, I'm big on magnesium and potassium for people that have hypertension, because hypertension can be treated effectively with potassium, and a lot of people aren't eating adequate fruits and vegetables. So these people that tend to be low in potassium, I don't like to use supplements, but because usually you can get that with food. Magnesium, you need supplements. 60-some% of the population is low in magnesium.